So it's a pleasure, of course, for me, and it's an honor to be part of this very interesting series, starting with pain management webinar. And as Dr. Farah mentioned, she gave us a full picture about pain and pain management. I will continue this series by talking about the non-steroidal anti-inflammatory drugs. So the objective of my presentation is to refresh and update our knowledge on these medications and their role in pain management, and to give a guide on individualizing their therapy based on patient factors, and to highlight some other indications for use of non-steroidals. So as Dr. Farah mentioned, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain can be acute, chronic, somatic, visceral, nociceptive, neuropathic, inflammatory, and usually it's overlapping. If there is tissue injury, the main thing, because I want to go into the mechanism of action of non-steroidal. So if there is a tissue injury, we know there is a release of inflammatory mediators like substance P or prostaglandins. And these, through a series of events, it will reach to the sensation of pain. So we have a large number of neurotransmitters and other chemical mediators that play a role in a pain processing and modulation, whether excitatory, like substance P, glutamate, or prostaglandins, or inhibitory, like opioids, norepinephrine, serotonin, and GABA. Pain leader or analgesic leader, the WHO one, mentioned that for the first step, we will use paracetamol plus minus non-steroidals. We know for pain medications, we have paracetamol, we have non-steroidals, we have opioids, but the first step in the leader is to use paracetamol plus minus non-steroidal anti-inflammatory drugs. If it did not work, still the patient encounter pain, we will add weak opioid. If still having pain, we'll go to strong opioid. So what are the non-steroidal anti-inflammatory drugs? These are non-narcotic, non-opioid. They are a class of medications that provide relief for many ailments due to analgesic, antipyretic, and anti-inflammatory effect in multiple health conditions. These medications are most frequently prescribed medications worldwide, accounting for, an example, 10 million prescriptions per year in Canada, 25 million prescriptions in United Kingdom, and 70 million prescriptions in United States. Why we call it non-steroidal? In order to distinguish these drugs from steroids, which have a similar anti-inflammatory action. So considering the efficacy of non-steroids for steroidal anti-inflammatory drugs for pain relief and their non-addictive nature, so we expect that the chronic use of these medications is increasing, especially because of the wide separate opioid misuse crisis. We have almost 20 different non-steroidals available commercially. So in order to understand or to refresh our minds about mechanism of action of these medications, we have to have some refreshment about the arachidonic acid pathway. So the cell membrane phospholipids under the action of phospholipase A2 will be changed to arachidonic acid. Arachidonic acid will have two main pathways, either cyclooxygenase or lipoxygenase. The cyclooxygenase pathway through two enzymes, COX-1 or COX-2. COX-1 is called the housekeeping or the physiological one that's available and it's expressed in the stomach, intestine, kidney, mainly concerned with the mucosal protection, renal blood flow maintenance and homeostasis, and platelet aggregation. COX-2 is called the inducible one, mainly in the macrophage and in the synovial and the inflammatory sites. It's mainly concerned with inflammation. So when arachidonic acid changed by COX-2 to prostaglandins, we will have inflammation, pain, and fever. The second pathway is the lipoxygenase pathway, where will be converted leukotrienes and also concerned with inflammation. So the two cyclooxygenase enzyme that we have, the COX-1, we said, expressed in the body, main role in maintaining GI mucosa lining, kidney function, and platelet aggregation. COX-2 is not constitutively expressed in the body. We call it inducible. So it is inducibly expressed during inflammatory response. So most non-steroidals, they act on these COX-1 and COX-2. Most of them, they are non-selective, but COX-2 selective only it means it will act on COX-2. So even the side effect profile is different. The important thing, COX-1 is the prime mediator for ensuring gastric mucosal integrity. COX-2 is mainly involved in inflammation. There is more than one mechanism. We know this is the well-known mechanism for action of non-steroidal, but there is some additional mechanism that I found, like the physical chemical properties of this medication make them easy to insert into biological membrane and disrupt some important interactions that are necessary for cell function. One of these is the uptake of arachidonate. Other mechanisms of action, it affects the neutrophil function. It inhibits the neutrophil function by decreasing the expression of L-selectin, which is a receptor at the inflammation, at the site of inflammation. So if the expression is reduced, so this will decrease the attachment of neutrophil to the inflammation site. And so it will not trigger the inflammatory response. So how to classify the non-steroidals? We said there is non-selective, acting on COX-1 and COX-2. We have 6 different categories. We have the salicylates, whether acylated, like aspirin, or non-acylated, like magnesium salicylate. We have propionic acid derivative, like ibuprofen. We have phenamates, like mefenamic acid, enolic acid derivative, like piroxicam, acetic acid derivative, like ketorolac or parazolone. And we have the preferential COX-2 inhibitor, which means it acts on COX-1 and COX-2, but more on COX-2, like diclofenac, meloxicam, and aciclofenac. And we have the selective COX-2, which we call it the newer, but actually long time now, we have it, which are the COXIBs, the celecoxib, etirocoxib, and the other. And there are a group called non-steroidal anti-inflammatory drug related to them. They have analgesic and antipyretic, but poor anti-inflammatory action. Example for it is the paracetamol or parazolone derivatives like metamizole, or benzoxine derivatives like nifopam. Just quick talk about paracetamol because it's related to the non-steroidals. We said it's a first-line analgesic in pain, in the analgesic ladder, can be used for acute or chronic pain. It actually, the new theories is talking about its effect. Also, it acts on cyclooxygenase enzyme, but a variant of cyclooxygenase 1, which is COX-3, which is highly expressed in the CNS. It have a good advantage. It do not affect the platelet function or increase bleeding time, rapidly absorbed. It have a significant first pass metabolism in the intestine and the hepatocyte. But we have to be careful with paracetamol. As Dr. Farah mentioned, paracetamol maximum dose is 4 grams. So if we exceed the 4 grams per day, in this case, this medication and the metabolite of this medication will be accumulated in blood, leading to hepatotoxicity because it should be conjugated to a glucurinated and sulfated metabolites. If we exceeded the neutralization activity of a glutathione of these metabolites, we will end up with hepatotoxicity. Let's go back again to the pharmacological classification of these non-steroidals. So we said we have non-selective. So from these non-selective, we have 2 types. We have irreversible non-selective, like the aspirin, irreversibly bind to cyclooxygenase enzyme, mainly which is COX-1. It is a cardioprotective. All of us, we know at low dose, but there is an increased risk of GI side effect. And we have the ibuprofen, naproxen. Those are non-selective, but they are reversible drugs. They have decreased risk of cardiovascular effect, but still they have risk of GI side effect. And we have those COX-2 preferential, like meloxicam, diclofenac, and the others. Those are mainly acting on COX-2, but we should use it with caution, because increased risk of cardiovascular. So the more going to COX-2, the more increased risk for cardiovascular event. Celecoxib is COX-2 selective, but we have to be careful. There is an increased risk of cardiovascular effect, but advantage of decreased risk of GI effect. So we have a balance. So this medication acting mainly on COX-1, they have high gastrointestinal risk or side effect like perforation, bleeding, or ulcer, and so on, and minimal cardiovascular effect. While those acting mainly on COX-2 have high cardiovascular side effect or risk like stroke, thrombosis, MI, or hypertension, and least GI side effect. So what are the factors that can increase the GI risk? The age, mainly more than 70. Concomitant therapy, if you are giving these non-steroidals with aspirin, with antiplatelets, with SSRIs or corticosteroids, there's increased GI risk. History of peptic ulcer, of course, alcohol or tobacco use of 2 or more non-steroidals. If you are giving more than 1 non-steroidal, I know there is an issue also on renal impairment, but also it affects the GI and increase the risk. Helicobacter infection and some severe illnesses and comorbidities. Here I'm sharing with you a meta-analysis of 28 observational studies demonstrated a marked variation in the risk of upper GI complications with different non-steroidals. Upper GI complications include GI bleeding, perforation, or peptic ulcer. The risk ratio, it ranges between 1.43 to 18.4, with the highest number, the highest risk ratio, higher risk, of course. So they found in this study that those medications with the least risk ratio were the celecoxib, ibuprofen, and aceclofenac, and those with the highest GI risk ratio were the ketorolac, the piroxicam, and azapropazone. What about the cardiovascular risk? Here is a systematic review also of observational studies that shows that cardiovascular risk, mainly MI, is increased in a number of non-steroidal drugs. Rofecoxib is the highest one, and this risk is dose-related. Celecoxib, there is no increased risk if we use it up to 200. If we use a daily dose more than 200 milligram, we are increasing the risk of cardiovascular. So it is, again, probably dose-related. Those with the least cardiovascular risk is naproxen, celecoxib, piroxicam, and ibuprofen, and the highest risk is with the rofecoxib. And here, the FDA in 2015, accordingly, they strengthen a warning that non-aspirin, non-steroidal anti-inflammatory drugs, they can cause heart attack or stroke. They mentioned that the risk of heart attack or stroke can occur as early as the first weeks of using non-steroidal, like if it is used for inflammatory, for osteoarthritis, or these medications are used for a long time, so the risk will be increased. So risk increase when you use it for a long period of time with higher doses. So non-steroidal increased risk of heart attack or stroke in patients, whether they have increased risk for heart disease or not, but the risk is higher for those with a baseline risk for heart disease. Some pharmacokinetic information about non-steroidals. These medications are absorbed completely, are highly bound to protein, to plasma protein. This is very important information because if patients have a hypoalbuminemia, like cirrhosis or active rheumatoid arthritis, maybe we need to adjust the dose of this medication because we will have high level of free drug in the blood. Half-lives, we have some short-acting, we have long-acting, but we have very important medication that these medications, some of them undergo hepatic transformations variously by different cytochromes like 2C8, 2C9, or 2C19. Why I mention this information? Because we know that this enzyme or this cytochrome 2C9 exactly is important for metabolism of a number of medications, including the non-steroidals. And we know non-steroidal have the potential to cause GI, renal, and cardiovascular effect. But what if there is a polymorphism in this enzyme? So polymorphism will affect the metabolism and clearance of several drugs in this group, and this will affect the drug exposure and potentially the safety. So there was a clear association between the polymorphism in this enzyme, and this enzyme gene, and the risk of non-steroidal related adverse effect. So accordingly, we categorize the non-steroidal into 2 groups. Those that are metabolized by the 2C9, so they are impacted by polymorphism, like we have ibuprofen, celecoxib, mefenamic acid, and the others. Or those that are not metabolized by cytochrome 2C9, so not impacted by polymorphism, like aspirin, naproxen, diclofenac, and the others. So according to the CPIC, the Clinical Pharmacogenetic Implementation Consortium, this is an organization that it is concerned with the use of pharmacogenomic informations for dosing of medications. So they mentioned if the person is an intermediate or normal metabolizer for this enzyme, this enzyme is an intermediate or normal metabolizer, so activity score 1.5 to 2, no need to change the dose. But if the person is intermediate metabolizer and the activity score is 1, maybe we need to initiate with the lowest recommended dose. And we have to consider other risk factors like age or hepatic impairment or others. If the patient or the person is poor metabolizer with activity score of the enzyme 0 to 0.5, we need to initiate the dose at 25 to 50% of the starting dose, or we need to use an alternative non-steroidal that is not metabolized by this enzyme. Talking about some adverse effect, we talk about the gastrointestinal, effect on the platelets, renal, it decreased sodium and water excretion. Actually, it enhanced the action of IDH hormone, the hormone in this case, and this is COX-1 and COX-2. It caused some hypersensitivity reaction ranging from bronchospasm, urticaria, rhinitis, or nasal polyps, and even it have an effect on the uterus, causing delayed parturition and dystocia. But the main thing to mention about it is the drug-drug interaction. Non-steroidals decrease the renal clearance of methotrexate, and this will result in a high methotrexate drug level. So if it is used as antineoplastic, these medications are contraindicated. But if it is used as a low dose for rheumatoid arthritis and other indications, we can use it the smallest dose for shortest period of time with close monitoring. These medications also attenuate the efficacy of ACE inhibitors. It blocks the vasodilator and natriuretic prostaglandin, so it counteracts the effect of ACE inhibitors and potentiate hyperkalemia. We have to be careful. We should avoid use this medication, especially the non-selective one, with warfarin and other anticoagulant, because it will inhibit platelet aggregation, platelet function, so increase bleeding time. And also risk of peptic ulcer increase when it's given with medications like glucocorticoids. But the well-known drug interaction is aspirin with mainly ibuprofen and naproxen, because this medication will attenuate, will reduce the effect or remove totally the effect of aspirin on a platelet. So we know that aspirin, it binds to the cyclooxygenase, the serine residue of cyclooxygenase enzyme, and irreversibly it will acetylate it. If we give ibuprofen, it will cause a steric hindrance, so prevent aspirin from its work. This is very important. So if it is no way, it's a must, we need to use ibuprofen with aspirin, we have to give it either 8 hours before aspirin or half an hour after aspirin. Reye's syndrome is a well-known disease, that it is rare disease, but actually it have a very severe consequences like encephalopathy, coma, fever, and fatty liver. It was correlated with the use of aspirin, so that it's contraindicated to use aspirin in any patient less than 16 years of old. G6PD also was associated with aspirin, with phenylbutazone or paracetamol. We know G6PD is the deficiency, is a condition in which red blood cells will break down when they are exposed to some drugs or food like fava beans. So although a lot of people, they are concerned about G6PD deficiency, but actually a lot of references, especially for aspirin, they say that up to 1 gram, and even some references go to 3 grams per day, is not associated with increased risk of G6PD, of hemolysis in G6PD deficient people. I think before aspirin were used for inflammation, for inflammatory, as an anti-inflammatory with high doses, but no more now. It's used in a small dose only. Some contraindications or precaution: if there is gastrointestinal disease, cardiovascular disease, chronic kidney disease, in patients at risk of renal insufficiency, such as those with intrinsic renal disease, heart failure, or cirrhosis. Also, there is a precaution. If the patient is allergic to aspirin, it's called aspirin exacerbated respiratory disease, we need to avoid the non-selective one. But celecoxib may be less likely to provoke symptoms in patients with penicillin allergy. Also, patients with chronic liver disease or hepatic cirrhosis, we should not use the non-steroidal, because there is an increased risk of variceal hemorrhage with the development of diuretic-resistant ascites. What about pregnancy? Before, there was a FDA drug safety communication that we cannot use non-steroidals in 30 weeks and beyond of gestation because of severe problem, which is closing the ductus arteriosus in the baby, which is some heart issues. But there is a new drug safety communication that 20 weeks and beyond, we cannot use it because this is associated with serious kidney problems in unborn baby. It reduces the volume of amniotic fluid. So if these women, they should use non-steroidal from 20 to 30 weeks of gestation. In this case, we'll use the smallest dose with the shortest period of time. So how to choose the best non-steroidal anti-inflammatory drug? So we have a lot of questions in mind before choosing which one to give to the patient or to prescribe as prescribers. So we have to ask, do the patient using any antiplatelet or methotrexate? Do the patient have allergy to aspirin? Do the patient have GI, heart, or kidney issue? Do they prefer once daily dose, or they can get it 2 times or 3 times? All these questions are in mind. Here is a very nice chart showing just a guide how to choose the best non-steroidal. So if the patient require non-steroidal anti-inflammatory drug, but have high GI risk, with high, and I'm starting with the left side, have high GI risk, have high also cardiovascular risk, and on aspirin. So once the patient is on aspirin, I would not use naproxen or ibuprofen. So either I have to avoid non-steroidals at all, or I will give celecoxib in a low dose, but we need a PPI with it. If the patient have high GI risk and high cardiovascular risk, but not on aspirin, either again to avoid totally, or we can give naproxen plus PPI or low dose celecoxib plus PPI. If high GI risk, low cardiovascular risk, celecoxib is good, plus minus PPI. It should be, actually, PPI should be given because there is high GI risk. If there is low GI risk, but high cardiovascular risk, and the patient on aspirin, low dose celecoxib, we don't need to give PPI. If low GI risk, high cardiovascular risk, but there is no aspirin, we can introduce naproxen or low dose celecoxib. If low risk, both sides, GI or cardiovascular, so any non-steroidal can be used. Some facts about the non-steroidal anti-inflammatory, some of these medications, like diclofenac, we know the maximum dose 150 milligram, but actually in US, they reach with the dose to 200 if it's used for treatment of rheumatoid arthritis. In Canada, they reach only to 100. And just to pay your attention that there is a free acid and there is a salt preparation. The salt preparation dose is 10% more than free acid. Indomethacin is the highest of the all non-steroidals with CNS side effects, like headache or altered mental status. This should be, we put in mind when prescribing a medication, the indomethacin, while Solindac is the highest with regards to hepatic inflammation and formation of renal calculi as a side effect. Mefenamic acid, this medication have a poor anti-inflammatory effect, but it is used mainly for acute pain and a lot used in our hospital for dysmenorrhea. So if it's used for dysmenorrhea, 3 days is the maximum. If for acute pain, 7 days is the maximum. Don't use this for chronic pain. Magnesium salicylate, this is maybe the future of non-steroidals because this is a salicylate but non-acetylated. It's not like aspirin because it have a lot of advantages. There is no significant effect of on the platelet function at usual doses. It relatively have lower GI bleeding risk than other non-selective non-steroidals. It may be tolerated at lower daily dose by adults, even with aspirin exacerbated respiratory disease or pseudo-allergic reaction. So maybe this medication can be used for patients allergic to aspirin. Celecoxib, we said at 200 and below, we don't have a high risk for cardiovascular. If we go up to 400 or more than 200, there is increased risk of cardiovascular and kidney risk, and these are dose-related. Etirocoxib is the highest in the coxib with regards to the cardiovascular risk, mainly hypertension. Quick, just two or three slides about other indications for non-steroidals. We have 2 more indications. We use it for preterm labor because this in labor, what happened in the labor affect the body in a way like the inflammation. So when the pregnant woman begin to experience uterine contractions, the body will start to release increased amount of prostaglandin and cytokines. So non-steroidals, prevent the body from releasing prostaglandins, and as a result, they will delay preterm delivery when given at the onset of preterm labor. Indomethacin is mainly used since 1970 in the second and early third trimester. We use it oral or rectal, like a loading dose, 50 to 100 milligram orally or rectally, and then we'll give it 25 milligram every 46 hours, maximum 72 hours. The second indication is with the patent ductus arteriosus. We know during the development of the fetus, the ductus arteriosus will divert blood from pulmonary artery to the aorta. So it will bypass the lungs. After the birth, this duct, it will be constricted and totally obliterated. If this duct remains patent, in this case, it will fail to close after delivery, so we will call it patent ductus arteriosus. In this case, if we need it to be opened because the patient will undergo surgery for ligation, in this case, we will give a prostaglandin. So we have to give alprostadil. If we need to close it, in this case, we will give a prostaglandins. So we have paracetamol can be used, indomethacin can be used, ibuprofen are used, all these medications are used to close the duct. The best of them is paracetamol with the lowest side effect profile, actually, but with regards to the efficacy, almost the same, all of them. The highest side effect with the indomethacin, the lowest is with paracetamol. So my take-home message, use the safest non-steroidal at the lowest dose for the shortest period of time. Patients on anticoagulation, oral steroids, low-dose aspirin, or antiplatelet medication should not take non-steroidal if possible. Among the non-steroidals, ibuprofen and celecoxib offer a favorable safety profile compared with other agents. Co-administration with PPI in patients who require a non-steroidal and are at moderate to high risk for GI toxicity is recommended. Cytochrome 2C9 polymorphism influence metabolism and clearance of several drugs of this class. Dose adjustment is required for slow metabolizers. I will end with this Pain Awareness Month, which is September in every year, where globally celebrated the Pain Awareness Month. With this, I conclude. Thank you so much.